September 16, 2021, Flathead City County Board of Health meeting to order. Welcome everybody. So that's all day. With that, I guess could we have a roll call attendance, please, Janelle? And I guess I'd like to congratulate Janelle on her new job appointment.
Thank you.
And it's great. We look forward. Audrey is up, so we have a good Janelle too. Thank you, guys.
Artist,
Here.
Annie, Annie,
So Zoom activated. And activated.
Annie, Bill,
Here.
Jessica,
Here.
Kyle,
Here.
Pam,
Here.
Pete,
No waiting.
Pete,
Yeah, Pete's here.
Pete, can you turn your mic on? Roger,
Here.
Here.
All right, thank you. With that, we'll move on to the approval of the agenda for today. So. Second. Okay, it's been moved and seconded to approve the agenda as provided. All those in favor say aye.
Aye.
Any opposed? Thank you. Okay, with that we move on to citizen comments. Is there many people out there?
there's just one.
Oh, great. Good afternoon. If you could state your name and address to the record. We're allowed 3 minutes for presentations.
Got it.
Thank you.
My name is Mick Riley. My address is box 809 in Glasgow, Montana. Hello, my name is Mick Riley. I'm 23. I've been living here for over 3 years. First of all, I'd like to say that there is not a pandemic. A real pandemic does not require constant media propaganda. A psychological operation does. Currently we have people in unelected powers of position, many who are foreign to the United States, making our public. If COVID is real and such a threat as told to us from the inescapable media, TV, radio, newspapers, where are the constant wailing ambulance noises day and night, the funeral processions in traffic, gatherings at graveyards? Can you die from the so-called virus at home, or do you have to go to the hospital for that? To move along, these injections are not experimental, they are perfected. They have had a long time to work on these, and they know exactly the intended outcome. If something is free, you are the product. What have we not been told recently? Go outside, get sunshine, eat healthy, exercise, socialize with meaningful people. In fact, you could argue the exact opposite. If you think Big Pharma wants you healthy, you're a conspiracy theorist. Now, to address the board directly, you're enabling a lie and you will be held accountable. The COVID story is so blatantly fraudulent. If you don't sense something is wrong, you're either an idiot or being intellectually dishonest. And I'd say every one of you, perhaps, is being dishonest, and you should be ashamed of yourselves. facilitating a lie, all because you're told so, likely with some sort of bribe as well. You kiss your child goodnight, and then you come and talk and vote about masking people. In a just world, you would be scared to walk the streets. Enabling the downfall of America, starting in your home county. It is disgusting, and I wish you would stop. I want to say the medical system does not want you healthy. They want a lifelong customer. There is no pandemic, only constant propaganda. These injections are not experimental, they are perfected. The majority of our leaders nowadays are cowards and traitors, and their day will come. Thank you for the time and opportunity.
Thank you. With that, I guess there's no one else in the waiting room, so are there other people on Zoom that would like to address the public comment? You can have a seat or. No.
Jessica,
So maybe we're.
Yes.
Thank you.
Thank you very much.
Thanks.
you are next to speak.
Can you hear me? Jessica Kirkendall here.
Thank you.
Hi, my name is Jessica Kirkendall. I'm a concerned Council resident and parent. I also lead a group, a team of healthy families for parental rights all across Flathead and all across Montana. I'm here because I've been involved with several groups of parents recently, trying to create a better environment for our children, trying to lead the path forward so that our children can be at school unrestricted and have normal childhood back, especially with all of the recent suicides at the local high schools and everything. We're very concerned about getting it back to normal for our children. What we've noticed with talking with parents across all of our 20 different districts in Flathead is that there's some confusion about quarantining of healthy students. Like I said, my group is very health conscious families, and we're very personally responsible for our family's health. If there's a health risk, or if someone is sick and has COVID, certainly they stay home from school. But there's a situation going on across our valley where many children are being sent home from school without being sick, and also a lot of talk of testing and testing non-sick children. And I keep hearing, that Joe Russell is helping with this, but I often, from my understanding, his position has been that it's a recommendation, which the schools aren't. A lot of the school superintendents are telling people it's mandatory. Particularly in West Valley, we had a good example yesterday where Superintendent Kell said that Joe Russell has told him that the quarantine of children under age 12 is mandatory at West Valley. Well, West Valley happens to be a school of K through 8th, so almost the entire student population is under age 12, and this is discrimination due to vaccination status, is why they've set their policy that way. Not they, I should say, the superintendent and Joe Russell have set the policy such that it's a clear direct violation of HB 702, where the children are being discriminated against based on medical status. So I don't understand why that sort of thing is going on. And I'm wondering if there's any chance of an idea or some guidance from the health board where we can get all of these school, we have 20 public school districts in Flathead Valley. And I'm wondering if there could be a statement made that the quarantine of healthy children is just a mistake, not only mentally, physically, explaining to a child why they need to be, banned from school for 2 weeks when they're completely healthy just doesn't make sense. As a parent, I feel like that's just a difficult thing to explain when someone's, healthy, and we always say, get a good education, go to school, and then they need to be sent home for really no reason at all. And so the more of this we continue, the more the cycle goes. The more testing you do on children, where, zero in a year and a half, 0 children and teens in the state of Montana have died of COVID. But now the schools are talking about getting COVID testing. Superintendent Cal at the West Valley School Board meeting said he can't wait to get a $45,000 grant to get COVID testing inside the school on the children. Again, if a child is sick, they stay home. If a child is not sick, I don't know how this is confusing. And also with HB 121 put in place, I'm wondering why this is still going on where each board and each group of parents has to go, set down these types of guidelines with the superintendent and try to make some common sense out of the whole thing. So just bringing that up and hoping that you can provide some guidance or maybe even a clear public statement that would help the 20 school districts, all of the children that are healthy, that don't have COVID, stay in school and have a good, happy, thriving educational experience this year. Thank you very much for your time. I appreciate your service. And if you have any questions, please do feel free to reach out to me. I'd love to get some advice on how we can work together to ensure that the children have a good education this year, a happy, thriving, normal childhood, and also, have some community discussion about how we can end the real pandemic at Glacier High with 6 children taking their own lives, a new, really serious, super sad problem that we're seeing. So thank you very much for your time. Goodbye.
Thank you. All right. I guess is there other Zoom?
No, that was the last one.
That was the last one. All right, I guess that will conclude the public comment section. We did have 2 written comments in our packet. Everybody had a chance to review. Thank you. Next item is the approval of the minutes from the July 15, 2021 meeting. Are there any modifications, revisions?
I put on the last page, my name is spelled wrong twice.
Noted.
No worries.
We'll fix that.
Easy fix.
Any other revisions to the minutes as provided? If not, I'd entertain a motion to approve the minutes as revised.
So moved. Seconded.
It's been moved and seconded to approve the July 15, 2021 board minutes as modified. All those in favor say aye.
Aye.
Any opposed? Thank you. All right, we're on to committee reports. The first one up is the Personnel Committee, who we are interested to hear from now.
Thank you. Thank you, Chair, and thank you, Board. So the Personnel Committee has been meeting since I think we started this process in May, when I first started updating that we were going to move forward with this process. Again, putting in that we had a CHS, which was a personnel employment contract that we were engaged in. Personnel Committee has met in June and July. In June, we did a salary survey just to be able to show look at other counties and what was going on in our current market. We knew that we had a couple of other officers that were being hired. We felt in that salary survey, felt our salary was in an appropriate range for the size of the county that we were, given that the smaller, given the size of the county that we were, it felt like they were appropriate size. There are, of course, larger counties in Montana that are paying their health officers more, but that is, we felt, due to their size of the population. The committee then reviewed the job description. So we had also reviewed the job description last year. So there weren't really many changes there to be made to the job description, but that did inform how we worked with the headhunter to update the job description and what was sent out and shared publicly. That description has the standards that we have from our MCA, put some standards on, Montana Code Annotated put some standards on us, our interlocal agreement, and then also just the county standards, put some job description of bare minimums of what we're looking for. We received applications over the summer. The closing date was August 13th for the application dates that came in. The committee has been, we actually ended up sort of doing a little bit of screening since August just to look through those resumes, selected I think a total of 7 candidates to interview. And then where we are today, and we were able to sort of have a committee meeting right before this. We are in a position where the Personnel Committee, we have 1 candidate that we are going to recommend to the Health Board to interview. We have proposed earlier in this process that we would do this next week. So we're shooting for next Wednesday, the 22nd, for the health board to do the interview of the candidate. And what we will do is similar process to what we have done before, which is a packet will be prepared for the entire board. And we'll share with you all those the job description, what the search looked like, but also the candidate that we're doing there. And they'll be sent to you as a packet. We're looking at doing a sort of the same approach where we break into subcommittees and have subcommittees do some interviews of the candidates. Again, for the health board. So that'll be 3 subcommittees. We're looking at doing those subcommittee interviews next Wednesday morning. We understand we need to work on schedule with everybody and confirm that schedule. So please, if we could get some response on how that works, but that will be in the morning. Then, because we are moving into that public process, so it's final round or second round of interview. We'll bring somebody here. The commissioners will also be interviewing the candidate that we vet. After that, then the health board will meet and we will decide if this is the candidate we want to recommend to the commissioners for hiring of the health officer. So that's sort of the process that we're in. But again, the committee wants to inform you that we do, that is the process of what we've done. We have one candidate who applied. I am confident that this candidate does meet a lot of our expectations. And there were some of those prerogatives of actually where we put environmental health, but also just our community health into priorities of what we're prioritizing is some skills and sets. This candidate is, I believe, I'm confident at the same level of our last candidates that we have interviewed. And that is what the Personnel Committee goal is to help us get to that round of interviews where we are recommending somebody who we believe is can fill the positions. And that's really where we as a Personnel Committee stand down. Though I will be around as chair of the Personnel Committee to just sort of help facilitate that last conversation that we need to have as a board. Because that's the Personnel Committee was just a vet for you, so that we all didn't have to sit through all those interviews. And I would like to, the Personnel Committee who joined me on that journey, it has been time intensive, but fortunately we've also had staff. And then we also have Andrew Nelson, who did all the first screening that we've been working with before, but also who the county has worked with and bringing in the county administrator and stuff like that. So I really appreciate the effort that everybody put in. But to say that we did have some good candidates there, but where we came down to is that we have one candidate that we have to advance. I'm happy to take questions if anybody has questions about that.
Any questions for Kyle? Just with that, I extend our appreciation to you, Bill, and Matt, and Jessica, for all your hard work on this, and keeping it moving forward. It's great. So, I guess we just need to get back to you on our availability. For
Yeah, so it'll be
Wednesday morning.
availability next morning, next Wednesday, the 22nd. That's so I can just sort of determine what the order of. We're looking at doing 45-minute subcommittee interviews. We have some prep questions that we've used before. I was going to review those with Joe and share those in the packet that will come to you. And again, once that we're there, I mean, the packet is covered by HR. So do remember that you're looking at something that is covered in that way. But we are going to have a public notice. The candidate's name would be shared, and I was going to work with HR so that candidate is aware of what the process is, but then also we're doing the notifications of when you guys will move into a more public process next Wednesday, September 22nd.
Right, thanks, Scott. Okay, we'll move on to the Home Health Committee. Dr. Kukic, you have a report from your committee?
Hey, Annie, I sent you one this morning.
Yeah, we met, we had a little ad hoc sort of meeting. It was very productive.
I just put some.
Okay. Yeah, I wrote up a summary after the last one, I sent it to Joe and the other people that were there. So we met August 16th. Primary focus of the meeting was to update the committee on problematic changes and current cash balance. Joe Russell mentioned the current cash balance of the program, approximately 60,000, and that balance has been relatively stable for the last few months. Accounts receivable, 315,000, with almost 200,000 posted in the last 30 days. Cheryl Rasmussen has taken over as the director. eliminated approximately 130,000 in fixed costs. One of the things I brought up is that the amount that we have in there, that amount, it's in part a reflection from the different grants and money that we got, so it's kind of looking a little better than it actually is. Joe Russell asked the committee how they felt about maintaining the program within the health department. And I mentioned how the program is beneficial to the community, serves members of the community not served by other licensed home health programs, and all the committee members concurred. And I had mentioned we had talked, several of us, about the past work of Dr. Meyerowitz regarding home health admissions and all the good work that he did. And I had thought maybe contacting him and seeing if he could get involved again, because he did great work in that regard. So that's about it. And we're meeting again.
But we did talk about doing it today, but since we didn't notice it, and I would be glad to work with you on noticing it.
Okay, sounds good. Thanks, Joe.
Right, any questions for Dr. Jack? Okay. Not, I guess we'll move on to environmental health, that's me. So Anna, myself, Artis, and Joe met on September 3rd, and we met primarily for one reason, to discuss Flathead County was awarded $2 million as part of the ARPA grant process. I was at a Flathead Basin Commission meeting last week and found out that the DNRC program director said that Flathead County got 7 of the $2 million grant. So Flathead County was very well in that initial cut. I think the city of Kalispell got a couple of those. I'm not sure what other groups did, but anyway, yeah, so Flathead County did great with that. So naturally, the $2 million isn't sufficient for the whole, I think the whole estimated cost for this thing was like $21 million or something. So what we do think that that's $2 million is adequate to start with preliminary site design, or actually find a site to weed out and see if we can find 3 or 4 sites that are suitable, and pin that down, and then go ahead with some preliminary design, like up to 30% or something. So our recommendation then, our subcommittee's recommendation is that we move ahead with a request for qualifications to hire a engineering firm to do that work. So is that a action item?
It is listed in the report, so you can move it forward.
Okay. So, with that, I guess. Anything, other things we talked about before we move on to that? This Kate Cassidy has returned as a part-time basis to assist with training of other younger employees in the health department, or the environmental health department, which is great. So with that, then I guess we would need a motion from the board to move ahead with going through a request for qualifications process to hire an engineering firm to do their engineering for the biosolids project. Anybody want to make a motion?
So that is the motion to accept the recommendation from the Environmental Health Committee.
Correct.
I'll make the motion to accept the recommendation from the Environmental Health Committee.
That's our clarifying that. Okay, it's been moved and seconded to accept the recommendation from environmental health to go ahead with the RFQ process and hire an engineering firm to utilize the first $2 million. Janelle, could you do a roll call vote on this, please?
Artis,
Yes.
Annie,
Yes.
Bill,
Yes.
Jessica. Yes. Kyle,
Yes.
Pam,
Yes.
Keith,
Yes.
Roger,
Yes.
Ronaldine. Yes.
Okay, unanimous decision, thank you. So, let's extent of our committee reports, we'll move on to the departmental reports. The first one is community health.
Killarney will be up in a second.
Hi, everyone. Hi there. All right, so an update for immunizations. August, we did really well with our immunization clinic. We held several back-to-school clinics, and we had 205 kids participate in those, ages 4 to 19. We had a total number of 112 Tdap shots, which is the one required for 7th grade. We had 29 rabies vaccines given in August. We continue to be steady in our travel appointments. And home visiting, we've actually had some pretty big changes over the past 2 months. So we underwent our RFP process for our home visiting grant. And in that process, it was told to us a big funding change for our WIC-B funding source with a 45% budget reduction. So for us, we actually had 2 staffing positions vacant at that time. So we didn't cut anyone with that budget reduction, but we are unable to fill those positions due to the budget cuts. We did successfully get that RFP renewed, which starts October 1st. But it is a big difference in the amount of families we'll be able to serve. Normally we serve over 100, 102, I think is our caseload numbers, and now it's a max of 65 with this new RFP process. So big change for our community. We do have a waiting list of over, I think this morning when we calculated, it was about 25 people on our waiting list, with 5 more just from today, so about 30. So we were trying our best to triage that wait list and get those people the services that they need. And then WIC, we continue to do remote services. A waiver got approved from the state to go all the way through November now. We were planning to reopen in September, but with COVID cases surging, they pushed the waiver to extend remote services through November. And we have pretty high, consistent rates of participation with WIC. Nothing's been drastically affected on that front due to COVID. And I do want to give a big kudos to our WIC supervisor, Janine, who's been with the health department for 30 years. She got the Outstanding Montana WIC Employee Award for this year. Wow, that's a big deal. Any questions for me?
Roger, if you don't mind,
Yeah.
a little bit on the home visiting. So we had a presentation a couple months ago on the home visiting program. And as you know, these are at-risk families, and a lot of our family referrals come through CPS, Child Protective Services. And the reduction in our grant, and this happened all around the state. This is not a Flathead County issue. This is the state health department that literally has dropped the ball on funding this program. And fortunately, we have Representative Frank Garner working with the director of the Department of Public Health and Human Services, as well as Bob Keenan. Senator Keenan's he's the chair of the committee, that interim committee that's working on it. So we met with those two not that long ago, and they're working hard to get that money reinstated. And quite frankly, it is time to get this program up and running. We have a lot of at-risk families, and just kudos to Frank and Bob for their work, trying to work with the director to try to get this money back in order. So it's necessary. I'm the first one to tell you that these are really at-risk families, and they need a lot of support. So thanks to Frank and Bob for what they're doing for us down in Helena. I think they're there this week too. So when you see them, say thanks.
So then Janine, our congratulations also.
I will.
Thanks, Killarney.
Hello. Hi there.
Your hair looks marvelous. I came to see you.
I know.
Just
Blushes.
that doesn't take much. Does anybody have any questions about the board report? I wanted to take a moment and introduce Sarah Pacheco. So she is our new CD nurse that replaced Lauren England. And so if you have any CD questions, she's been the one that's been doing it all for the past, is it about a month now, or
Yeah, over.
about a month? But I wanted you guys to be able to see the face of who's doing all the hard work in that report that you guys get every month. So if you have any questions, this is Sarah.
My name is Sarah Pacheco. I graduated from Montana State in 2020 and went to work down in Roman at the hospital, which was fantastic. Back up here because the commute was a little bit much, and I'm excited to be up here with you guys. As a senior nursing student, I got to have Lauren and Jill actually, and so that was kind of my first introduction here to the health department, and now obviously I'm in communicable disease.
So does anybody have any questions about the CD report? There's a few little outliers that were on the CD report, all the way down.
Yeah.
You know,
Yeah, so the outliers are that ehrlichiosis, that one, that person had been traveling over to the East Coast, so that kind of explains that. That is not something that we had reported cases here in Montana, so that's good. That transmissible spongiform encephalopathies, or prion disease, that one right now, we just have lab results from when that person was living, 98% chance of a prion disease, currently awaiting autopsy results. We were able to send specimens back to the National Prion Center in Ohio. And so we were able to coordinate that with a surgeon out of Los Angeles. So.
Any questions?
Just one, I mean, this is our department that we would have previously had a suicide, some suicide funding and looking at some of those community outreaches, and as public comment noted, but I think a lot of us know it is an issue. What is that looking like? I know it's a hard issue, but I'd love to see.
so we
where
don't
we are.
currently have any suicide funding for it, and it was only for adult males. We weren't allowed to touch anything beyond men in the middle. That's what the grant was specifically for. So we actually work very closely with the Nate Shute Foundation. And then Malia and I are working with the Nate Shute Foundation, the Sheriff's Office, and KPD to come up with a suicide review team to start reviewing suicides and start pulling aggregate data so we can start seeing if there's trends or anything like that. I know that as the community, I know that the Nate Shute Foundation, which is primarily for youth, Sheriff's Office, and some other organizations, and the KPD, and then some other parent organizations are working to bring in some help to the schools. So we are more of we're a data collection group. We don't have the professionals to be able to address those issues. We don't have mental health professionals within the health department that can address that. But we are working to try to help in any way that we can for data collection or whatever it is to try to support them as they go through this really difficult time. So,
Thank you.
any other questions?
I was going to raise a question about the biggest elephant in the room that is not displayed here. And then I was handed the packet. This will be part of your report. And I think it's particularly important that we emphasize this because there's so much information, disinformation, and dishonesty in the community about the seriousness and lethality of the current COVID crisis. And I'm sure the health officer will report on this.
Yeah, we try to keep it we compartmentalize to try to keep our other programs going and realizing that we do have the big elephant that we are fighting every day.
There's a wealth of information at the health department website that I look at almost daily. And I've been able to predict trends just by looking at the numbers. I hope that the current peak is about, or we're experiencing very, very close to the peak. And that so many of the people that aren't getting the bug are those that are unvaccinated. We were called collectively stupid about 45 minutes ago and dishonest. The dishonest people are the ones like the one who was making the presentation. So I urge you to look at this report mostly coming up and look at the website at least once a week to see what's going on.
So just one more point. Sarah, it probably was about 2 minutes after 8 that you hit the ground running and have not stopped. So thank you for joining the team and literally hit the ground running. I think the first thing I heard out of the mouth was rabies. And, we just kept going after that. So welcome aboard. And Jen has lost a really valuable staff person to admin, sort of. Malia Freeman is actually taking the EPI job, but she's filling a lot of roles. She's still doing our public information as well as step straight out to get involved with suicide stuff. So we're all in on that. We will not ignore. It doesn't take money for us to be involved in programs, and we are, as Jen will tell you.
We just met with Brian yesterday to start doing the coroner reports and trying to pull the data so that we can make it as aggregate as possible so that people are not able to do identifying. Once we bring it back to a collective group that can then evaluate, we'll be working with Logan Health and other mental health professionals around the valley to be able to look at that data, but we needed to de-identify it first. And so Malia and I are going to take that role as a de-identifying and then go forward from there.
Thank you. I disagree, and I know, Joe, that it's a priority for us, and it's where the health department becomes a really important partner to the community. Like you say, we do a very valuable connection of our data, but there's also about how to lead these conversations.
Yeah, and it's definitely, I think there's a lot of leaders in the community that are stepping forward that are really seeing it. And as Malia and I've been trying for a while, and now we're really getting some momentum going forward. So
It's a challenging issue, but I appreciate your assistance.
Sarah, welcome aboard too.
thank you. Her hair looks great too.
All right, environmental health, I guess Kate's out, so you're probably on
Yeah,
the
I just
agenda.
probably, it's striking, I've not seen the table. And that would be my fault, Janelle, because I put the order, I put this in, but usually you'll see the table. The activity in environmental health, as you know, is still at a pretty frenetic clip. We're down a staff person, grateful to have Kate back, but we're still flipping along at a pretty good pace with, the septic system permitting. We are pushing down for another 3 weeks.
Didn't Christine come on board?
Chris Bond came on board. She's doing a lot of, we're very fortunate. She doesn't mind doing non-degradation analysis. So we're like, here, do those. And so she's doing those for us. Because of the salary savings we've had, I'm gonna probably keep her on until we feel very caught up with, probably up till November-ish. I hope the board doesn't mind. We use temporary services when we have salary savings in environmental health director and Kate's not working full time. So I apologize. We will send out that table that you usually see, but the activities are pretty strong. And you can see that once again, our food safety group, looking around and seeing some of these scores, and that's not easy.
No.
It is not easy to get a low score and walk out of there. It is a hard job and it takes a lot of support. They support each other very well, and I support them quite a bit because food safety is a really important aspect of public health. So if you see them, tell them thanks and realize that when you see a C or a D+, that's a hard concept. That's a hard thing to do. And first thing I do when I see a score like that, I talk to the secretary. Thanks for doing this. It's not easy to do. And as you probably know, we're the only county in Montana that posts scores. And it was the work that, back, Bill, you will recall some of the work that we've done, all of our policies around that are super well received by this community. They'd like to see scores, and they'd like to know and the other thing, and this is policy, just realize that when a low score does happen, they don't wait 6 months. We are back there within a short order, days, to to redo that, especially when their track record is they usually do well. We don't want to see a poor score posted. They had a bad day. We'll get it corrected. They'll correct it. So I love this program. I think it is a sentinel program for this health department and for the state of Montana. And it takes a lot of effort for them and the board to support this type of activity. So that's all I have, Roger.
So I had a question with this one facility in White, there just seems to be a reoccurring. Why do they keep having so much problems?
Well, a lot of it this is a big corporation.
Yeah.
And they have had trouble staffing. And if you look at the FDA risk factor surveys that have been done, the primary reasons food safety scores are low is managers. Managers are the prime, if you don't have a strong manager looking at all aspects of food safety, oftentimes you will find that the root of that will be. So they actually came back and did it pretty well on this follow-up score. And they are also signing up for CertSafe. So I think someone woke them up and they said, well, we need to put a little more into this. So they're gonna have a large component of staff for CertSafe, and hopefully that'll start to help. But that's you see, we did a lot of work at the fair. You know, that's the other thing I want to mention about the staff. And this is just the whole environmental staff, the whole health department staff is wrongly professed to me earlier. You know, that they do a lot of work after hours. And they just, a lot of our staff starts early and just to get things done. So, but the fair is always a time I hate the fair. I say that. I don't know where it all came from, probably when I was doing inspections as a young sanitarian, but I didn't like it. And it takes a lot of work, and they really prepare foods, especially now that we didn't have none of the carnival food booths showed up this year, which is always a nice thing, because they're the most challenging. But all of our not-for-profits that are out there, we have a great relationship with them, and we can tell them how the stores work out there. They're not doing much in here. Okay.
All right, thank you on the environmental health. So the next one is the animal shelter. Everybody,
Okay, we're gonna go to Cliff now. So that's why we put them up last.
Sleeping now. Peace and quiet.
Good afternoon. Members of the board, esteemed colleagues. So I will be brief. At the animal shelter, probably the biggest things going on are our 5 animal care people. We've had 2 leave this year, and like all employers, it's been difficult replacing them. To make it a little more interesting, the third of 5 has been out for 5 weeks with an illness. So that's a little tricky. But we're getting through that. A good crew. So I think the main thing I was going to talk about today, we kind of talked about cat population management, and that's our biggest area of criticism. And so one of the things that the IT department is really great to work with. And I said, why don't we link this report on the website where people can see, because people go to the website and they look and they say, gee, there's 6 adoptable cats and 3 strays. You could fit 100 cats in there, you heartless so and so. Why don't you, why are you having people on a waiting list? And it's because there's actually about 19 more cats that aren't of age or health problems, haven't been spayed or neutered, and they're neither spayed, or they're neither stray, I should say, nor adopted. So we're trying to get that word out a little better. And I think that having that report will help and show, it's a nice report from the standpoint that it's a 12-month look back, and it shows how many cats came in and how many cats went out. And so we can get people to go there. It'll be a little easier. And the month of September always makes me hold my breath, because the first cold morning, the phone starts ringing. I've been feeding the cat all year. He's gonna die tomorrow morning. You gotta take him in. We don't have room right now. Our capacity for care, we follow the guidelines of the Association of Shelter Vets and Million Cat Challenge, and try and explain that. So that's, I think we're being proactive with that. I hope that, and again, we do have really good people. When someone comes in and their emotions are a little tightened, I know they get treated with respect and courtesy, and hopefully we'll get through October and September, and we'll be fine. Other than that, I'm looking forward to having bids open on our new building this next week. I hope doesn't mind if I drop in. But that's an exciting time. So that's what's going on at the shelter. Any questions I can answer?
So you still see, obviously, you're like dogs in at 72 and you had dogs out at 82. So you have some puppies, but is that just because of,
50-50.
is that because of the COVID, people are still wanting to adopt?
It's probably, Roger, probably carryover from the previous month, where in July, we took in, I think it was 100 some. And some months, one of the dynamics that give us a short length of stay on dogs is that we have a really high return to owner rate. And so the ones that are up for adoption, if I were to break them out for you, they probably average 15 to 20 days in the shelter. And some days we adopt out 7 or 8. So I think that's why in this particular one.
Seems like a great place.
We do a good job in getting them out of there. And when our annual report is on that same website. And if you look last year, it compares us to 10 other Montana shelters that use our same software, and about 1,500. And we really have a short length of stay. And oftentimes shelters have a short length of stay because they're euthanizing every few days, and we have a very respectable low euthanasia numbers. So by following what we're taught by industry experts, we're short length of stay, low euthanasia rate. Very proud.
Does anybody have any other questions for Claire? All right, thank you much.
Thank you. Good afternoon.
Thanks.
What we've all been waiting for is the health officer's report.
So you can follow along. I think you can all follow along on the computers. Sorry, you weren't sure if you would be here. And I set you up.
Yeah, you just did this.
Just look at new cases over time. I think Bill received one of the situation reports. Lisa's on vacation this week, and she needs some time off. So Bill had asked, well, gosh, 106, we had 160 new cases one day. Bill thought, that's as high as we've had in a long time. It was back in November, all the stuff we had, these types of numbers. I actually look at this and have some, I'm not an eternal optimist, but sometimes I feel that way. And I think our vaccination rates are actually helping us quite a bit when you think of the fact that the Delta variant might have an R naught or an infectivity rate over 4. The first generations of coronavirus, SARS-CoV-2 probably ended up with a 1.5 type.
Can you explain that term? I don't know.
So R naught is actually the infectivity rate of the packaging. So some of the things that you should always know, measles, R naught is like 18. Means for every one measles case in an unprotected population, you could have 18. So this is that infectivity rate. So once in a while, you'll hear R naught or you'll hear infectivity rate. You know, initially when Delta came out, they thought this is good. This is an R naught of 7. And it's not. It's probably more like 4. And I think a lot of that's actually being driven by overall vaccination rates. You know, if you think about it right now, not even talking about the conferred immunity based on disease, 1 in 2 people in Flathead County have at least one vaccine. We're at 49%. So, you know, those are some things that we have to keep into consideration. So when you think of a highly infected variant like Delta, and the fact that we aren't seeing the cases we saw, you know, prior to 2021, I mean, that bodes well for what we're doing. And we never want to lose the fact that we do get conferred immunity based on previous infection. And that all lends to it. Right now, we're 15,000 people in Flathead County that have had COVID. Diagnosed COVID, it's probably higher. We know that it's clearly COVID disease is underreported nationally. So, you know, we're doing okay on just that whole incidence of disease. I think we're managing it from a staff perspective. We're really focused on schools. Now, I want you, some of the things that were mentioned today, and I want you to be very clear about our COVID response right now. We are very much, and I think Jessica mentioned it, my name came up in the West Valley School Board meeting yesterday, and actually it wasn't all negative. It does. I talked to Dr. Bull's wife, Krista, and I had that conversation, and I tried to explain to her our response. And before I move deep into our response, my overarching hope is that we keep our schools open. And that's why we're doing what we do. So House Bill 702 does hamper our ability to respond. And House Bill 702 is, as we have discussed here, House Bill 702 is a non-discriminatory act, ACT, on vaccination status. Some of the things that you've heard earlier about 0 to 11-year-olds, House Bill 702 has no impact on a non-vaccinated public. Just keep that in mind. So we are, and I spend a lot of time trying to tell people what isolation versus quarantine is. And I always, this is the major concept, and I'll tell our staff this, and sometimes people will say, we got a sick person in quarantine. Well, Jessica would be the first one to tell you, no, you have a sick person in isolation. You quarantine exposed, and you quarantine them, and they are well. Usually when they go into quarantine, they are well. But you quarantine them because they have a high risk of contracting the illness that they came in contact with. So yes, it's really, some people don't get the concept that you quarantine exposed and you isolate ill. And everyone kind of swishes and swatches through that. And I always want to make that clear. That's what we do. We had some cases out in where Jessica grew up, and of 4 people that we put into quarantine, 3 of them became ill. So that's why we quarantine, because exposed people do end up contracting illness. So keep that in mind. Back to your point earlier to me, I think we're in a manageable phase, basically due to the fact that we do have some conferred immunity that we didn't have back in November. And I think that's really good. The next 3 slides are just information on the just cases in June, July, and August. Primarily, I keep putting these up so you see the average. In June, before Delta hit, I thought we have this thing licked. And then you can start to see July hit and Delta came in. And then August, our average was 61.71 cases per day. And these are all, once again, let's go back to House Bill 121, so you understand that my job is to comply with the law. House Bill 121 changed the definition of isolation to where you could not, what we call, you could not determine an epi linkage between the case, even in a household. So if, let's say Jeff had it and you had symptoms, before 121, we would consider you a case of us. We can't do that anymore. We can't build epi linkages. House Bill 121 changed the definition of isolation and quarantine. We only identify cases that are lab identified. And we have pushed that to the point where we, although schools may take some action on these small lab antigen tests, which we give out, we don't consider them a case until we get the information on a lab or healthcare provider issue. Puts us in a little bit of a time frame crunch, but we really want to follow the law. So we're pushing for lab identified cases. I am working with the school district on rapid antigen testing sites. Hopefully I'll find some more out. If we're doing anything, I'll notify the board through both committees. So Delta is a more infective agent. We can see that in everything that we look at. So if we just keep moving, next concept. If you look at this and if you go, well, golly, Joe has some color in his slides. This is the first time I do not like colored backgrounds, but I thought I could do this just for a little,
Wow.
just to change,
Very sharp.
just to change it up. Now, there's a lot of things that go into this. When you look at disease in the community, and we look at let's look at the children cohort. If I told you that 22% of all population in Flathead County were 0 to 18, you would go, yeah, I can look that up on the census of 104,000 people, but based on US Census data. But we know that 0 to 18 is 22% of our entire population. So when you look at widespread community spread, okay, when we think of community spread, but now we look at this smaller cohort, and most of this cohort is school-age children, right? I can back out 0 to 4, and I can tell you that the population of school-age children is roughly 18% conservatively of our entire population. So what I did with this is I took and looked at the incidence of disease in that population, and I charted it, and I put a Mendoza line on there. And I used 22% because I'm still using 0 to 18 on this. I've refined it a little bit more. But if you look at this and you see that, can you go back down, Janelle? If you look at that white line, as long as it stays under that trigger point, we have less community spread in our schools than we do just generally in the community. Now there's some significance around this, and some extremely confounding evidence that we are over-reporting in 0 to 18-year-olds versus what we're doing in the general population. Now, some people will say, why do you say that, Joe? Well, schools are ultra sensitive to symptoms right now, and we are doing a lot of testing. So I would tell you that because we're over-reporting in this age group, that maybe the trigger point could be. So I'm still looking at the data, and I'm still thinking, and what I do this for is to help the schools understand what the community spread looks like. Right now, I think the schools, even though they're very busy in their response, I think the community spread is less than we're seeing in the entire community. Their transmission rates are less than we're seeing in the entire community. That's good news. It's not great news. I'd like to see that line right at the bottom. And I'll show you, maybe keep going, Janelle. So this is another, can you go, it's total cases versus cases of 18, 0 to 18-year-olds. I think you want to go back up. So if you look at this, and you got to look at it with some thought in mind that we're looking at kind of the incidence of disease in the general population charted against the orange 0 to 18-year-old group. Where we haven't seen us, so when you go way back, 11% of all of our the incidence of all of our disease is in that 0 to 18. It's creeped up a little bit, it's like 14% now. But I keep looking at the data, thinking, are there trends that say our schools are at risk, more at risk than they are, just based on the data? So I look at this. And I'd like to see this, and I've looked at it from, the slope of the line, and if we're not seeing the same increase in the school age 0 to 18-year-olds that we're seeing in the general population. You can see that from the line. So let's just maybe keep going.
The question, is that totally consistent with the national statistics?
What I think is consistent.
I say general, not total.
What I think is consistent is the rate, the increase in incidence of disease caused by Delta has been around 3 times that what it was.
I'll get that later.
Yeah.
Okay, good.
As you know, I like to follow this total test versus positivity rate. Of course, we've had more disease, so our testing went up. And if you look to see that that line, that positivity rate has climbed over 20%, those are really tough numbers when it comes to how CMS deals with our long-term care facilities. And I didn't want to talk a lot about them. They're really frustrated with the cases of outbreak status. And we have so many of our long-term care facilities in outbreak status. And I wish we could start to move them off. You realize that we have 2 full-time equivalents working with long-term care, try to get control of this activity. And so we continue to work on it. Very close to the last plate. As I mentioned, you see from this table, 49% of our entire population is now has at least 1 dose. I think we're at 44% considered fully immunized. When you add the 15% known positive cases plus probably maybe even another 10 at least, we have some very good converted immunity in the community. Just have to realize that's the only thing that's combating the Delta virus's higher infectivity rate by that far not. So, that's helping us a lot. And everyone knows I'm an advocate. I'm not pulling punches. I'm an advocate for this vaccine, and it tends to work. But let's look at one more thing that I've been tracking. Destroying it. Okay, we've seen that. Is there another plate? I wanted to just show you one more thing. Breakthrough cases. Before Delta hit, our breakthrough cases were 1.23. That means we were literally, and that's a percentage, we were literally, of all of our cases, 1.23%, sorry, I dropped the percentage on there, were breakthrough. We were looking really good. Once in a while you see a breakthrough and you go, what in the world's happening? Now we're seeing breakthroughs at a lot higher percentage. And a little concerned about that, but when you think about it, I think the last plate on there is a Logan Hospital plate. One of the things I think from, and Dr. Pete would, I know he's on, he would be grateful of this was Logan's data last Wednesday. Of the 37 that were in there, there were 5 breakthrough cases. None were in ICU and none were on beds. That's pretty good news. And I don't have enough time to talk about the misinformation that happens at the federal level of health. I can't believe we can keep our heads on it with all the information that comes out and how it changes so frequently. But I'm pleased. I think it's doing what it's doing. I'm happy with our staff's response, and I'm grateful for the schools and what they're doing to try to keep their schools open. And you know, it was the first meeting that I started with this health officer. I told you, if we can keep our schools open, if we can keep our businesses open, we can make this. But if our schools close and our parents have to go home and take care of their children, we're gonna see a disruption in commerce, and that affects the public stuff. That's why we need to keep the schools open, and we need to keep our businesses open. And one of the things, there are a few businesses that have gone back to masking of their staff. I respect them, and I put a mask on when I go into there. I just respect their policy, and I put a mask on. You know, it's interesting that it's different now. People aren't attacking mask use. They're just not, and I'm grateful. And it's not that we see tons of people in them, but we're seeing people put them on for whatever reason. I'm sure you have yours, and I have mine, but I respect businesses that require their staff to put them on and outfit to wear. But I'm not seeing anyone look harshly at them. I'm very grateful. I think our community has gone past that. Super grateful that we're not seeing that same level of hostility. And, thoughts on that. Let's go through a few more things. We had 2 health officer orders. Any questions? I mean, I don't want to. You probably know that I really delve into COVID response, and I have great staff and a lot of people doing good stuff. But I wanted to mention the health officer cease and desist orders. Stillwater Landings food service activities have subsided based on weather. And we're going to work with them this winter. First of all, as you recall, they have a subdivision violation going on because they can't operate a restaurant with the certificate of subdivision plat with the statement that they have. They don't have enough land to do what they're doing either with all the other activities. But the true owner of the property has some other property, and I think we can possibly get them to work with a consultant to do a boundary line adjustment and put enough land in there to rebuild their septic system and take care of their glamping units, the camping units that are on there and everything else. So working on that. David Randall's working on Pete's Fried Chicken. And next step is probably some action that will include the Montana Building Codes Bureau on the action too. And expect that to happen very soon. Interlocal agreement, just an update on the interlocal agreement. We had Pete Melnick and I met with the city managers the week prior to last, and great meeting. And I was really surprised. They were very receptive to what was put forward. They kind of freaked out when they saw Terra's first draft that had 3 commissioners on there again. Did you hear about that? Yeah. They what? We never talked about that. So just so you know where we are, Columbia Falls City Council is already approving it. They're on board. They like it. They want to move forward with it. I think that's great. Kalispell and Whitefish both have it on their agendas. I think they're under their city attorney reviews right now, and early in the first week in October, they're going to take action on it. I actually meet with the Kalispell City Council next Monday night, and I know that this will be on the agenda to discuss. I'm very supportive of it. We do need to make sure once we get this thing approved, and hopefully it's in October, November, we need to work on our bylaws. Because the execution of 121 happens in the bylaws. The over the 1,000-foot level is covered in the interlocal, but the nuanced issues on how we move through regulatory changes are going to happen in the bylaws. So we're going to probably extend our bylaw. Roger, I haven't really talked to you about this, but I think with that, we'll want to do that to include the commissioners, because it's going to wrap into the whole government discussion. But I have some really good thoughts in mind on how to do this. Keep you in suspense. Last thing, I'm teaching a Zoom instructor development workshop next week, and I'll be in, I hope I should, but I'm sure. Sorry, Bill. And I'll be in Tucson the following week teaching instructor development. Do not know if this class in October will happen, but I've been asked to teach a community healthcare planning and response to disaster course in Kansas City on the second week of October. These in-persons are all, I just got my plane to Tucson, so they could be stopped like that. Questions of the health officer? That's what you should have said.
I do, if I may.
Sure.
Can you estimate the relative size of the two cohorts, excluding the underage, who have immunity either through vaccination or having caught the bug, versus those who have no immunity at all? And my guess is like 65, 2/3 and 1/3.
I think you're right. And
Pretty close, anyway.
What you would do is just take 2/3 of 92,000.
Okay. With that very rough statistic,
60,825.
Yeah. Versus 30,000. So,
That was for you.
Yeah. okay. Can you go back to the chart on the hospitalization? This is available every week. It's published. I think it's on Tuesday for the prior week. It's the number of hospitalizations. Until she brings it up, there were 37 people in the hospital, 9 of them in the ICU, 7 on ventilators. Of the 37 people in the hospital, 5 were breakthrough cases. And that statistic has varied for the last couple of weeks, being somewhere between 10 and 15%, maybe 16% of the total. So not only are the sickest people in the hospital are unvaccinated, the sickest of the 6, the 9 in the ICU and the 7 on ventilators. There's not a single person there that has immunity. So if you're here's the statistics I'm trying to calculate. How much more likely, given the recent history, the last month or two, with hospitalizations and the rate of infection, and most of it is because of the Delta variant. How much more?
Do you mind if I?
Yeah, go ahead.
So when I did the report, 98% of all cases are Delta variant, because they're doing gene sequencing. But I just got a report this week. So everyone's kind of freaking out about the mu variant. It's not even a variant of concern. It's not even that infective, and it's not very pathogenic. So it's not even a variant of concern right now. 100% of all of our cases are Delta as of last week. All of them.
How much more likely is someone who has no immunity to get the bug than those people that do? It looks to me like it's about 10 to 1. It's almost a magnitude.
Based on breakthrough.
So the counter to the argument that we heard from this young man, it's not the people who have the jab, have the inoculation. It's the people that remain afraid to take it, or for whatever good reasons they may have. But they are the ones that are most at risk, and they continue to be at risk to a very significant degree until they take the vaccination. Is that a fair statement?
Whatever, however you get converted, most people that are naive.
We're getting closer.
Most people that are naive to the virus have to get a vaccine. I mean, that's.
Thank you, Mike. Jess, you may want to add something too, because you have the same medical background. Dr. Andy, you too.
So it sounds like, if I'm understanding it, you're saying that the presupposition is if you don't get vaccinated, you're gonna get sick and really sick. And the vast majority of people understand, don't catch it and do just fine. So if you're saying that vaccines should be mandated, we should.
No, I'm not saying we should be mandated.
Okay.
I'm just saying, in making a decision for yourself or your family, you should look at the data in front of us, which says you're much more likely to get sick if you don't have any immunity, either through vaccination or having survived.
And that's where vaccine choice comes in, where if people look at that data and they're impressed that they should get it, the vaccine, then they should get it. And those that look at that, and they're willing to take their chances and they've done well, they should have that option. So it's a fine piece of data to present to people, but it's still their choice whether they get it or not. And I think the people that haven't been real impressed by data so far from the CDC and other sources, or maybe even question the reliability of it, those people they're not gonna be likely to get the COVID shot. So we're probably dealing with the same population difference there. So it would not compel most people that I know to get it.
It's interesting that you watch the rate of uptake is super reduced. And I agree with what you just said. It's their decision to make.
Correct.
And my conservative friends were to tell you that it's probably not really fond of mandates. In general. I mean, you want people to make that choice.
Yeah, individual choice.
And it's
Vast-
interesting.
The
It's
vast
in-
majority of people do
Yeah.
just fine without it, so.
And so it's interesting that we see what we see. This is totally anecdotal. But the people that are coming in to get vaccinated now aren't happy, not excited. They just feel that they have this resolve, they gotta get it. Whether they need to go travel somewhere that they want to go, or they see something on the horizon that it's going to impact them. There's just not the same level of happiness that we saw in like March. You know, people are like, oh my God, I'm going to be free. It's just now there's a different tenor to the vaccine clinics. We don't care. We just want to get it vaccinated. So
Yeah, it's probably a skewed population, the enthusiasts for vaccines that are probably lined up. I mean, I know that's true in my patient population. The ones that are get enthusiastic about this kind of thing got enthusiastic right off the bat.
Yeah.
And then the reality of difficulty traveling or the coercion from family members to get it, or you're not going to be able to see your grandkid, that kind of thing, over time that wears away on people. So I think that's probably the reason it's different
That's what we're
populations of people.
Yeah.
Got questions for Joe?
Joe, though, are we seeing reinfection of people who have caught COVID before being able to catch the Delta variant or be able to catch COVID in general?
So we do track reinfection. It's a little harder to track because they have to be identified going to the Montana Infectious Disease System. But we do track them. We do see a couple of reinfection, which is, or we're just missing data. So we do track it, and we just don't see a lot of reinfection.
But it is happening, and that's an assumption that Bill is making there, that somebody might not be affected.
Very easy to look at vaccination status. It's really hard. There's way more weeks in the way.
And people are a lot more frightened, there's no question, and so those people, maybe more of those, if they've been worn down and they're gonna get a vaccine, even though maybe it's not really within their immune system to get one. And people are getting more testing, they're calling me, I've got sniffles, or had a cough for 2 days, I'm scared, should I get tested, should I go to the emergency room? There's a lot more of that. And that leads to more testing, which leads to more positive tests, whether it's, reasonable or meaningful data or not. The validity of the testing has been questioned for a long time now. So that's part of what we're dealing with. And when we act as though the sky is falling, we're all gonna die, and man, you better just sign up for things, that's ignoring the CDC data for Montana that I've shared with you. It's extremely positive, 99.9% survival rate for people that have been, that tested COVID positive. I just say tested positive, because it doesn't mean they're sick, but of those, the survival rate has gone from, in the middle of July, 98.5% to 98.6%. So with all the skies falling because of Delta virus, the survival rate has actually gone up, and that's CDC data. And we know from multiple sources, including the head of the CDC, Robert Anderson, Deborah Birx, the head of the Illinois Department of Health, they've all admitted more or less that the death rates are inflated. So that's, a lot of people believe that. So when you see 98.6% survival rate for those that test positive, that could very well be an inflated number in terms of the deaths, which means probably the survival rate is even better than that. And so when you look at that and you look at the latest numbers, from the CDC in Montana, the actual COVID positive rate in Montana is less than 13%. And so to act as though we got to get the vaccine, the sky is falling, you're going to die if you don't get it, anything that promotes that and is scaring people into getting tested more is not realistic. It's not based on data. So I've sent you that data. I sent you the CDC sites. I'm trying to think if there's anything else. So I've already sent you that. And again, keep in mind, COVID positive test, it just means it's a COVID positive test with a test that may or may not be, reasonably measuring anything, and it does not mean the person is sick. So the more contact tracing we do and well people, the more positive tests you're gonna get, and it just feeds the cycle of fear. So you look at the numbers in Montana, they're excellent. Joe is a very optimistic person, and his report was optimistic, so I don't feel like I need to say too much in response to that, so I'm responding a little more to you than to Joe.
Just one comment. We are doing a lot more rapid antigen tests. And what we're seeing is, and I'm supporting them because they're much more, they're rapid. That's why they're called rapid antigen tests. And what we're doing is the same thing you're seeing is that they'll get a home test, positive, and they're going, what they're going to do is stay home, or they'll want to go get it confirmed. Some need it because their employers, they're being able to go back to work, like even in Flathead County. If you're out for 2 days, we may require a doctor's note that you can return to work. So it's interesting that we're seeing a lot more rapid antigen tests, and I actually like that test for a lot of reasons. And one of them is getting something back and not waiting 3 days, and the fact that it's way less costly. And what we're seeing is this, we are seeing a lot of people that want to test. And I think that, a long time ago when we first met in my office, and we talked about personal responsibility, I believe that most people don't want to get other people sick. And that's why they're testing. And that's why they're staying home. Whether they ever get into our system, like getting a lab identified and it comes through as a positive, most people don't want to get other people sick. And yeah, there are some people that don't believe COVID-19 exists. Most people do. And they don't want to get people sick. And that's why even, your patients say, I got a they don't want to get friends sick, and they don't want to, So we could talk a lot about the social determinants of health and where, those people like Ron, we used to employ that can't afford not to be at work because they have all these bills to pay and they don't have any money. But we'll leave that to another subject of, this is a huge subject. This is the psychosocial stuff that drives people to go to work sick, right? And some people to stay home. And at the end of the day, it's really about personal responsibility and making good choices. And
Sure. And one more comment about the testing, including the rapid antigen testing. I mean, the testing that we used for a year and a half, there are multiple layers of evidence that it was, even Fauci said last July of 2020, that it creates meaningless data at a second threshold of over 35 or over 33, whatever it said. So we used a test that creates meaningless data for a year and a half, and we shut down schools and businesses, all kinds of things over meaningless data. And now the new test, the public is supposed to suddenly believe that it's more accurate, when the reports that I've got, it supposedly has a specificity of 100%. I'm sorry, I've been doctoring a long time. There is no such thing as a test with 100% specificity. So a specificity for what? An antibody? Well, or, does that mean they're sick? You know what I mean? So it's like, it looks like based on that, and that we've got another meaningless test, or there's some suggestion that it could be. And so we're creating fear over something that the meaningfulness of it, the value of it is questionable at a minimum.
It's interesting because I actually had this discussion with myself in my bipolaris one day. The thought that it could have 100% specificity, like the answer says, that just means that you're not going to get false negatives, right?
But it's positive for what? I mean, we don't have any tests like that.
But
So what are they
it's
testing?
really good at determining that you're not sick.
Highly unlikely. It means that if you get a positive test, it 100% means you've got it.
But that's
what?
sensitivity though. So,
No, specificity, it's specific for it. Sensitivity picks up everything. You can pick up all kinds of.
that's positive predictive.
Specific for COVID, specific.
Right, so the sensitivity of antigen testing is like 90% at best.
That means
In asymptomatic, it's like 35%. It's a terrible test for asymptomatic. Anyone who comes in and gets a test, we literally tell them, don't use it unless you're symptomatic. Because it's not a good, it's terrible at doing surveillance testing unless you have super high viral load. Then it starts to get better. But it doesn't have a good sensitivity. It has tremendous specificity.
And specificity means if it's positive, you have it. That's
No,
what sensitivity is how often do you pick it up? That's sensitivity.
Specificity is the ability of the test to correctly identify those without the disease, the true negative rate.
That's why it's so good.
And the corollary of that is that if you have it, it means 100% for sure you have it.
No, it says you're not true negative. So it says if you come back false, you don't have the disease. That's what that is.
But
If the true negative is 0, it means the true positive is 100. There's no such test. It doesn't work that way.
oftentimes, Andy, we don't use the test for that same purpose. We're either determining.
Again, back to my point, we had a meaningless test for a year and a half, admittedly meaningless by Fauci, and now we have a test and people are supposed to believe it.
So I guess we will.
Okay, can I make a point here? So,
We get Dr. Pete, and then we're gonna move on.
I thought this was coordinated comments.
Well.
Okay.
What is it?
So the way this is working can you hear me okay?
Yeah.
Okay, so the way this is working in real time in clinics is the PCR is still the main test that's being used because of the increased sensitivity of the PCR test. Okay, so the ability of the antigen test to be offered, what's nice is that we can give it quickly. So if the antigen test comes back positive, that confirms that patient has illness and and test as it's considered a positive test, and we don't need to go any further because it may miss because the antigen test may miss some because the antigen test has a higher threshold of viral load needing to be detected. There are some people who may be infected that the antigen test does not pick up And that is why for those people who test negative on an antigen test, we may retest them with a PCR. And so it's not that the test is that the antigen test is invalid. It's that the ability to pick up a lower viral load on the antigen test is the threshold is different. So then we default to the PCR to really confirm if it's negative. And like Joe said, the antigen test is not a good screening test for somebody who's asymptomatic. It's just, so that's where the PCR is still going to be the main thing for an asymptomatic person. So that's how we're using it in real life in our clinics. So I just had a couple quick questions. So in the PCR, is still the main test that we're using because of its amazing sensitivity to pick up small amounts of viral load, which is what we want, right? We want to be able to get to catch people early and be able to tell them that they're may be at risk of spreading virus and can isolate appropriately. So I just had two questions for Joe about the health officer report. Number one was what you mentioned that it sounds like you felt like things are pretty good from the health department as far as management. What is the current time now between notifying patients when patients test positive and when they are getting contacted by the health department to do a contact trace? Like what are we looking at in terms of lag time? Are we looking like a day or two? Where is that right now? And the second question I have is our communication with the teachers, especially at the elementary level, that close quarantine is that quarantine for close contacts is not up to parents can't opt out of that. That is a actual that is quarantine is not optional. It or advised that at that age that it actually is an order from the health department. What has been our communication to the schools as far as that's concerned? So those are my two questions.
So we talked a little bit about quarantine earlier. The 0 to 11-year-olds, House Bill 702, doesn't touch that group, so they are being not advised to quarantine. They are being told they need to quarantine if they're a close contact.
But is that message being relayed to specifically then like the elementary school teachers who are really on the ground level, at least with advising helping determine which patients have been close contacts with, or which children have been close contacts with positive cases?
So I want to say yes, but I can't answer that in the affirmative because you gave me an example and I had a call regarding the same thing. When we first came out with our advice, our guidance to schools, everything was quarantine advisory. And so we didn't discern, the difference in 0 to 18 or 0 to 11 and 11 and above. So we have changed that. That has been guidance set to the schools, but because of our original message, the new message may not have all been received by all teachers. The superintendents know this and they're trying to reinforce it, but based on early guidance from the health department, there could be some confusion. Hopefully we can get that cleared up.
Okay, yeah, I just think that's important that we get that mix up again, especially on a teacher level, because they're the ones on the front line of that right now.
To answer the other question, it depends. If it's a school-age child, we're making folders within the first hour of work on that age cohort, and we're moving on working those cases right away. If it's a 45-year-old, we may be 3 days before we get to them. That's the level, the volume of activity. So what happens a lot is the 45-year-old that needs something to be excluded from work or to return to work, they're asking for letters from us and we are providing them. But that's not much different than last year. You know, we're focusing on healthcare. I mean, our two at-risk populations are schools to stay open and healthcare. So we're not messing around. There's no time lost in those, but just the general healthy workforce could be a couple days.
And okay, thank you. And just one last comment again from just talking about vaccinations and for the people that I'm seeing in my office on a regular basis. You know, I would agree with one of the comments earlier that it's not you know, it's not the same kind of joy and jubilation with people you know, with people getting their vaccines that it was when they first were made available. But I think the main people who are realizing that vaccination is in their best interest, certainly it's not because of fear. There's no, it's not a fear thing. I think what it is, the people who have realized that it's in their best interest are doing so because they're realizing that that vaccination decreases their risk of serious illness. And early on in the pandemic, our biggest concerns were obviously people with a lot of underlying health issues, our elderly, et cetera. And now people have realized that just being middle-aged they are just as likely to, they are at risk of becoming seriously ill, and that doing a safe and effective intervention will significantly decrease their risk of becoming seriously ill. And so people are sometimes maybe a little reluctant to accept that, but when they realize that people in the hospital aren't just the extreme age with lots of medical problems, that it's really just a lot of regular people who are in the hospital who didn't get vaccinated, then they see that applies to them. So again, it's not a fear tactic, or it's more of a realization that they are at risk. And even though people don't like to accept that, that's the way it is right now. And the really good news, and this is fantastic news, is that people who do get vaccinated have a high degree of protection, and all of the data supports that. So we're going to just keep laying on that message over and over. Again, not in the attempt to fear or coerce people, but just to educate them that it's the healthy thing to do. So, and that's the end of my comments.
I got a question for you. So it sounds like if somebody has a positive rapid antigen test, it's assumed that they have it, and they don't have to go on to further testing. So that would support my discussion of the practical aspects of a specificity of 100%. Isn't that what you said, that if they have a positive test, they don't have to go to further testing? It's accepted that they have it. Is that correct?
If they have a positive antigen test, again, that's confirmed, say that is confirmed, we don't go on to additional confirmatory testing after that.
Comfortable they are positive, which is the practical aspect of what I was saying.
But they have been symptomatic. That's.
But we're not. But then to Joe's point, we are not doing them on. We are not doing those tests on asymptomatic people, because your whole point in doing it on an asymptomatic person is you're looking for a negative to rule them out, and that's not the appropriate test to do in that situation, because the sensitivity on a PCR is higher.
our geologist wants to.
All right. I enjoyed the invigorating discussion.
We are invigorated, that's for sure.
And we'll move on from the health officers and medical communities reports.
Actually, I have
I am offended that you don't find sensitivity, specificity, negative predictive value as an invigorating discussion. That does hurt my feelings a little bit.
Wrong with you, Roger.
I learned immensely being on this board. So we'll move on to questions about department reports, and I believe Ron Lee has a question.
Yes, so I appreciate everybody who's able to present, and also I did look at the reports that are from the departments that aren't able to present. And one of the things I watched closely is the syringe exchange program. And we haven't been getting a lot of reports on that. And so I would like to see if we can get a little bit more information. I'm seeing a high number of needles going out, but not coming back. And part of public health is, I think, that we're missing some of this. It looks like the 12-month total, we had 92,000 syringes distributed, but only 50,000 were collected. And so there was, pretty good steady. We had a really good report of, maybe about a year and a half ago that really showed the reason why we do the exchange program was so that we have more opportunity to have contact with people who are in the drug addiction and more opportunity to help them get some help. And I'm just concerned with the number of needles going out, the lack of number of needles coming back, with the focus being that we have had on COVID, that we're missing some of the other things that really are important to our community. And I'm seeing a lot of needles publicly being posted, that they're being left in parks, playgrounds, and parking lots. And so again, that's just a concern I wanted to bring up.
And I will, maybe we could have a special report at our board meeting.
But I hate to make it just my
No,
question. but I
no,
think
this
that-
is really good, and I think just maybe to pile on this, it was mentioned that Dr. Meyerowitz, who was on the board, had said, are we seeing any benefit? And maybe we need to look a little bit about blood-borne disease over the last 2 years to see what's going on. So I will charge the staff to do that. But Ron, some of the reason why some of these needles aren't being accounted for coming back is they're going into our other program, the one that we use, that we partner with the solid waste, because we don't count those. So I think a lot of them are actually going in the right direction. They're getting out of the waste stream. I'm a little concerned about any waste, not in the waste stream, protecting the stream. But let's have a report. Let's try to give you a pretty good, great point. And I just talked about this morning or yesterday morning with me. So I'll bring that up.
Thank you. Thank you.
Yeah. Good point. All right, any other questions for the department regarding departmental reports? If not, we'll move on to board member comments. If anybody's got one, I'm not going to ask everyone to do it.
I've got one. I sent it to you in an email, so I'll just read it. It's kind of related to what Ronald was talking about. We've already taken a number of steps to supposedly protect us from COVID, but what is the cost? What other things have been neglected, like you talked about? Politicians are demanding we hunker down. Can we do things a little smarter this time? Can we keep from punishing our citizens for the sake of conformity and style? Let's do a better job this time. Below, I gave you a partial list of some of the people who took the brunt of the suffering and with the last mandates last year, and we got to do better. Number one, delayed and missed cancer diagnosis from delayed labs, radiologic studies, biopsies, and so on. Two, prolonged suffering due to delayed surgeries or surgeries not done, people's joints grinding and pain. Three, old sick Americans, productive all their life, were destined to die alone without the benefit of the comfort of family and friends. Four, seniors already abandoned in long-term care facilities, placed in solitary confinement, normally used for punishment in prison. Number five, hardworking couples with their life savings in their mortgaged house, invested in their mom and pop small businesses, lost everything and were evicted from their foreclosed homes. Number 6, one of the worst things that mandates do is set Americans against Americans. Vaccine choice, mask choice does not divide people, mandates do. That's my comment.
Any other comments, Kyle?
Thank you, Chair. Just a reminder again, next Wednesday morning is when we're looking at our Board of Health interviews. If you could let me know what your schedule looks like, Tammy and I will finalize what that schedule is and break us into the different groups that we have, and get that information out to you as soon as we can. That will include candidates information. And then of course that will be a publicly notice. And then when I sort of heartened by Annie's thoughts about those, I do think that there's a lot of issues out there that was my questions about suicide. And I think that there's a lot of issues in the community that I do hope that we also are able to prioritize and move back. I respect people's public comments, but the mayor and I have generally recently been taking offense to when us or our boards are getting accused of taking kickbacks or being liars. And I know I don't take kickbacks. I know that the rest of you, I believe, don't take kickbacks, and I don't believe you to be liars. So I really appreciate your service on the health board, but I do take offense when we are getting regular public comment that's accusing you of that. Now, defense. I don't believe that is true. It's been an honor to serve.
Thank you, Kyle. I'm sure we all share your sentiments. Never forget what somebody's gonna say.
I understand.
With that.
I'd like to say one last thing.
Sure.
Yeah, so just going back to what Dr. Annie just shared, obviously we're all in agreement that we hate seeing other things that aren't being addressed because of the COVID pandemic. So, and the really good news about this is the more of us who get vaccinated and are protected, the fewer of our health resources will be going towards taking care of sick people in the hospital. So I trust that Annie will join me in encouraging people to get vaccinated so that we have less of our health care focus being on COVID and being able to take care of the other things that people get ill from. Thank you.
All right, with that, yeah. Is there a motion to adjourn?
Chase, you guys.
Motion to adjourn.
You guys are wonderful. Thank you.
For adjourn.
All right, sir.
All right, thank you, everybody.
All right.
You know, we're getting.